Position your body so that your eyes are at a distance from the patient that facilitates binocular vision. Hold the laryngoscope in your left hand, blade down. Open the patient's mouth with your right hand. Insert the laryngoscope blade to the right of the patient's tongue. Gradually move the blade to the center of the mouth, pushing the tongue to the left. Visualize the epiglottis. Ideal placement of the laryngoscope blade depends on whether a curved or straight blade is used. Place the tip of the curved blade into the vallecula between the base of the tongue and the epiglottis, and lift anteriorly to expose the vocal cords. When using a straight blade, place the tip of the blade just past the epiglottis and lift anteriorly to expose the vocal cords. When the tip of the blade is correctly positioned, lift the laryngoscope upwards and forwards at a 45-degree angle. Direct the force of your lift along the axis of the laryngoscope handle in the direction of the ceiling over the patient's feet. Avoid bending your wrist or rocking the blade against the patient's teeth, which can result in dental or soft tissue injury and will not enhance the view of the glottis. If available, an assistant should gently pull on the right side of the cheek to enhance visibility of the glottis. Hold the endotracheal tube in your right hand. While maintaining your view of the vocal cords, insert the endotracheal tube into the right side of the patient's mouth. The tube should not obstruct your view of the vocal cords during this critical part of the procedure. Pass the tube through the vocal cords until the balloon disappears into the trachea. Remove the stylet and advance the tube until the balloon is 3 to 4 centimeters beyond the vocal cords. Inflate the endotracheal balloon with air to the minimum pressure required to prevent air leaks during tidal volume ventilation with a bag. This usually requires less than 10 cc's of air. The assistant must maintain cricoid pressure until tube placement in the trachea is confirmed. The end of the endotracheal tube should lie in the mid-trachea 3 to 7 centimeters above the carina. A good rule of thumb is 22 centimeters at the teeth for the average size adult. Place the end-tidal CO2 detector onto the endotracheal tube and attach the ventilation bag, administering a few tidal volume breaths. Carbon dioxide will be reliably and consistently detected within the first 6 breaths of an endotracheal intubation, and with each exhalation thereafter, except in some cases of cardiac arrest when gas exchange may not occur. Assess secondarily for esophageal tube placement by auscultating over the stomach during positive pressure ventilation. Auscultate both lungs in the mid-axillary line to assess for equal bilateral air movement. If breath sounds are diminished on the left side after intubation, you may need to gradually withdraw the endotracheal tube until symmetrical breath sounds are auscultated. Chest radiography is used to assess the patient's pulmonary status after intubation and to ensure that the tip of the radio-opaque line embedded in the endotracheal tube is well positioned at the level of the mid-trachea and not in either mainstem bronchus. Note that radiography cannot be relied upon to detect esophageal intubation. Secure the endotracheal tube to the patient's head once proper position has been confirmed. If available, you should use an endotracheal tube holder to secure the tube, as these devices aid in the prevention of accidental displacement. If such a device is not available, tape may be used instead. First, attach the tape to the patient's cheek and then wrap it circumferentially around the tube. Next, affix the free end of the tape to the patient's other cheek. Pharmacologic sedation and hand restraints may be employed to prevent inadvertent extubation. The most serious complication of endotracheal intubation is unrecognized esophageal intubation, which may lead to hypoxemia, hypercapnia, and death. Laryngoscopy can provoke vomiting and aspiration of gastric contents, causing pneumonitis or pneumonia. Additional complications include bradycardia, laryngospasm, bronchospasm, and apnea due to pharyngeal stimulation. Trauma to teeth, lips, vocal cords, and exacerbation of cervical spine injuries can also occur.